Thank you. Okay. Whoa, I hadn't noticed the patch until now.
Oh, I thought it was a flower.
It's really cool. It's like a little umbrella thing. So
yeah, it looks like it has one flap that goes on one side and one flap that goes on the other side of the septum.
And you can float it up. So that's the occluder. So you float the occluder in through a catheter, and you push out the catheter, and the umbrella opens and stops up the hole.
Whoa.
Oh, cool. I gotta find a YouTube video. Can you go back up to symptoms, Will? Sorry.
Mm-hmm.
Back. Yeah. So we said, I don't know what I wrote in my notes. I put extra pump. What do you think she meant? Maybe I didn't finish writing everything, but extra pumping?
Extra.
So I have increased respiratory rate, increased pulse rate, periorbital edema, probably a murmur, respiratory.
Is tachy the same thing as increased? Oh my gosh. Okay. Slow down.
Yeah.
Oh, my bad.
I'm from North Kakalaki. You have to slow it real slow.
And then they'll be more likely to get like pulmonary edema and pulmonary like fluid on the lungs.
Yeah, and more respiratory infections.
Did they differentiate right heart failure from left heart failure? Just talk about. Because right heart failure is more likely to cause like edema in your legs and your liver to get big. Left heart failure is more likely to back up in the lungs and cause congestion in the lungs and increased respiratory rate. The tachypnea is fast breathing, tachycardia is fast heart rate, and both of them occur in congestive heart failure. Crackles are a good thing. I mean, are a common thing with congestive heart failure when it's left heart, lung back, when there's extra fluid in the lungs.
Okay.
Something with the patch that I'm curious about, does it grow with the child?
It does. It has to be made out of something that can grow. So I don't know how many of them are artificial now versus using a piece of pericardium. But the pericardium is the layer that's around the heart, and they can take a piece of pericardium and sew it over the hole.
Oh.
And then it can grow with the child.
Oh.
Wow.
Do they still use pig valves?
They do. Yeah, they use a nicer word called porcine, but that's pig.
In order to sew it, do they have to stop the heart?
They do. So they have to get on bypass.
That's crazy.
But the umbrella
That's actually a
doesn't have
specialty in the OR. What's that called in the OR?
So
you're doing the.
They're called perfusionists.
Yes.
And they basically take over and until they're done, and they give it back to the anesthesiologist. But perfusionists and perfusion techs, we used to call them pump techs. It's a huge thing, and it's really cool. I mean, they're kind of like really fancy plumbers, and they're so essential.
My friend's husband is one of those.
It's really cool.
Do you have to stop the heart for the umbrella?
Nope.
Okay.
What do perfusionists do? ECMO?
Yep, they do. I'm sure they're on part of that team, because that's like, it's the same thing. Instead of in surgery, it's just taken over for the heart and the lungs.
Wait, what's ECMO?
If the heart's pumping, then the ECMO can just be stealing blood and sending it through fake lungs. So I don't know who does ECMO. We don't have it at our hospital, but the same tech can do both.
What is ECMO?
Extracorporeal oxygenation through membrane. It's just basically it's artificial lung. extracorporeal membrane oxygenation. That's what it is.
Hmm.
Maybe
It's like a dialysis, but for oxygenation.
Yep. And
Mhm.
the heart's still pumping, but I know the ECMO machine provides pressure too. So I think it just makes it easier on the heart
Hmm.
and just bypasses the lungs.
How long do they do it for? Is it constant?
Yeah, constant, but it's the longer you're on it, the worse it is for you.
Got it.
I saw somewhere it's like the most extreme version of life support. I think it's pretty-
Exactly. And the longer you're on it, the less likely you'll ever get off it.
Mm.
So is that what they use to keep organ donors going? I assume.
I think so. I'm not sure. Yep. That's a good question. I don't know.
Are we talking about like minutes or hours or days?
Like with COVID, it was like one of my friends who's a pediatrician was on ECMO for a week. And he was on a ventilator for 4 weeks, but ECMO was an extra week. So he had 5 weeks of being on some sort of support, and he's still not okay.
I was going to ask that. Yeah.
He can work a half day, but he can't stand for more than 15 minutes without getting out of breath.
Wow.
Oh, gosh. See, it's not just about survival rates.
I know. Exactly. It's really much worse.
Right.
Two big tubes coming on both sides of your neck. It leaves awful scars.
Mm.
So
I don't
go ahead.
I don't understand how ibuprofen and acetaminophen can be used to close the
Yeah.
whole, reduce inflammation maybe, but I don't see how it closes.
So prostaglandin is the chemical that makes the PDA want to close, and it's surged at birth, and those are prostaglandin inhibitors. So I didn't know acetaminophen would do it, but typically it's indomethacin they use. And it's the reason it's funny, they recommend to women at the end of their pregnancy to take ibuprofen or any of the ibuprofen analogs, but I didn't know that acetaminophen would close the ductus. If it works, it's kind of cool.
Did you say it's purged at birth?
I mean, no,
Or
I
it
don't know what.
surges at birth?
It's increased at birth. The prostaglandin levels drop, and
Okay.
the oxygen by itself usually makes the PDA close. You want to stay open, and a blue baby, it sometimes closes anyway. So they keep it up with intravenous prostaglandin.
So you give them more? Wait.
If you want to keep the PDA open.
If you want to keep it open, you can prostaglandins.
Give them
prostaglandins. Okay.
But these
these two.
medications listed are prostaglandin inhibitors.
So if you want to close the PDA because it's the only thing that's open, it's providing abnormal blood flow. The aorta becomes the high pressure system, and it pushes blood through the PDA back into the pulmonary artery, which you don't want. But if it stays open for some reason, it can sometimes be closed chemically with indomethacin or tied off. One thing that's kind of interesting from just a plain old vital signs perspective, if you have a new baby and he's really blue and he's breathing fast, but he's not working hard to breathe, it's like the difference between tachypnea and dyspnea. If his work of breathing, he's comfortable, but he's really blue, you should always think heart. Because if it's a lung kid, like a pneumonia or a premature lung disease, they should be working hard to breathe and blue. But if they're just blue and they look happy and they're breathing fast, always think heart disease.
Is there any idea why indomethacin thing only works for premature babies?
I don't know the answer to that. I should, but I don't know.
I mean, they did mention in class that they don't know why.
Okay, me neither.
Okay.
What number are you on? Oh, I see it.
We would go for
I guess you got all the questions on that one, right? 39
A and B.
should be A. Yeah, A and B.
And E.
And heart failure too?
Yeah, I think. Yeah, I don't know with cohort. Maybe if it's. I guess if it's tight enough. Yes.
Yeah. Was that one of the answers in the lecture, Anna?
Not clubbing for sure, but I think yeah, A, B, and E should all be right.
How often do you think that these go missed with modern children, like the ones born nowadays?
The definitely you can miss the cohort because they may not have a murmur, and so my partner had a kid who came in and was 7 years old, and he had a cohort, and he just got tired when he was running, and he was way less endurance than he should have had, and he had a huge difference in his pulses in his upper extremities and lower extremities, and a huge disparity between his upper extremity blood pressure and his lower. So both the strength of the pulse and the blood pressure. Some of them are you're not going to miss the blue baby because every baby gets a screen now at birth where they check for pulse ox readings in the arms versus the legs and blood pressure arms versus the legs. So those all get picked up. And then the moms get really high quality ultrasounds now, and those ultrasonographers pick up a whole lot of congenital heart defects. So not that many get through, except for you couldn't see a cohort. ASD, you can miss that. And if ASDs get old, they can have lung damage from increased blood flow to the lungs and may not have a murmur at all. And that hasn't happened to me, but I've always been afraid of that. Is missing an ASD, and they developed something called pulmonary arterial hypertension, which is permanent. And that can be missed also.
Mm.
I'm trying to wrap my head around the pathophys behind the difference in the upper extremities and lower extremities, like why it will be higher in upper extremities.
So that little, if you see that picture of the body, that really just goes to arms, head, both arms and head. So those three vessels take care of both arms and the head.
I see.
And but the lower extremities is down below.
Yeah.
That
Past
makes a lot of sense.
So it happens after what is that little tri of arteries there? The sub.
Innominate and this is on my oral board, left and right.
Okay. So it was right before it goes to the descending aorta where that coarctation usually is.
Right. So the blood that exits the heart goes to the head and the arms before the cohort. And the cohort usually takes place right where the PDA would have been. So it's almost like the PDA closing and over closing and causing a scar with some.
Here we go.
There it is.
Oh, yeah,
Brachiocephalic splits into right subclavian and right in the right common carotid, and the left carotid, which goes to the brain on the left side, is already split. So the one that's called brachiocephalic splits into two right after that.
Okay.
Brain.
So that's your head and both your arms.
Well, yeah. This is an arm, this is a head, this is arm and head.
Right.
All right. Hey.
I'm so glad I asked that.
That was a great question, Anna.
It was an aha for me during class, and I figured that they had explained it in the lecture and I had just missed it, but I was like, because I missed that question on the quiz. That was the one that I missed, and yeah.
So do they make a point about the bicuspid and tricuspid like
Mhm.
mitral and tricuspid, like the mitral valves in the ventricles, in the left ventricle, and it's only 2 valves, and the tricuspid's between the right atrium and the right ventricle, and it's 3.
Mhm. You try before you buy.
Oh, I love that.
That's great.
And which mitral is this one?
Uh-huh.
Mhm.
It seems like, oh well, doesn't matter. So you got bi's on the right. I'm sorry, right heart is tri, left heart is bi.
Mhm. Would the skin assessment be to check for cyanotic skin, or is there something else I'm missing?
I think so, perfusion, edema. Does everybody press on somebody's leg with, that's a gross picture, with pitting edema for legs?
What in the world is going on here?
I don't know. It's a blue man.
Yeah.
Hang on, I'll mute myself for a second.
So this is the lecture where I feel like I was the least paying attention. So I
Me
think
too, because I couldn't stand her voice.
yeah, my attention was just shot by this time. I didn't mind her voice. I appreciated you saying that because it set my standards really low. And then I was like, I'm okay with this.
Me too.
But,
No,
but
that-
at lecture number 3, I just didn't have it in me anymore.
That would be a great program for us to develop, is a way to change the voice that you hear during lectures to something that you find more, you know, that you're more attentive to. Because I think voice has a lot to do with it.
Yeah.
I would put Will's voice every time.
Oh.
You can't really change the intonation.
I would go with that. I have a monotone voice and I hate to lecture. I like to talk to people, but I hate to get up for a lecture. And I hate to give lectures at 1 o'clock because everyone just ate and they all go to sleep.
Yeah.
So shunting, go ahead, sorry.
I can't listen to lectures where the speaker is doing the upspeak because everything sounds like a question.
I don't have any tone variation at all. So shunts are really important. If you think of right to left shunt, that just means they skip the lungs. So it's always going to be a cyanotic defect if it's right to left. And the TETs would not be, would have increased blood flow if it weren't for the fact that they have pulmonic stenosis. Because they always have a big VSD also, but the pulmonic stenosis keeps the lungs from getting too much blood.
Is that Phoebe?
They're both going. I don't know what they're both doing. Phoebe and Ben.
Why doesn't giving them oxygen help with the cyanosis for this?
That's a great question. It doesn't really, it increases the oxygen in the blood, but the serum can hold very little oxygen. So it helps just a little bit to hyperoxygenate. But if a red blood cell goes through the heart without going by the lungs, it's still not going to get any oxygen at all. So everything that goes through the lungs is going to get almost as saturated as it can. And then anything that doesn't go through the lungs is not going to be benefited by the oxygen you give them into their lungs. So does that make sense?
Yes, thank you.
And what does the serum have to do with it?
I mean, serum can carry a little bit of oxygen.
So like, how do you get oxygen to the serum? Is it through the lungs also?
Yeah, through the lungs also. So you might be giving them a little extra oxygen, but it doesn't do very much at all.
I see.
Yeah, it wouldn't be carried by the hemoglobin. It would just
Right.
be oxygen just diffused into the.
Yeah, just getting a little bit more oxygen into whatever bit of blood is going through the.
Not much.
Did they say why these things all go together?
No, but it's a really common defect, but I don't know the answer to that. It has to do with some point in embryological development of the heart. All defects happen at the same time. Something I think is important. It's nice to understand, and they didn't mention it. If you think it's too much, just say that's too much. But when babies are born, the pressure in their lungs is still really high. And it takes a few months for the pressure in the lungs to drop. And so sometimes they're born without a murmur and they're asymptomatic from their VSD. But after a couple of months, the pressures in the lung drop dramatically. And the right heart pressures are low compared to the left heart pressure, because the left heart has to pump to the whole body, and it's the big muscular chamber.
Right.
So sometimes babies look fine for a while, and after a few months, the blood flow from the left heart to the right heart dramatically increases. So they might not have congestive heart failure until they're 2 or 3 or 4 months old. And it's just pulmonary artery and the lung vessels themselves, all the pressure drops, increases shunts. And in that case, with tetralogy, the blood flow is limited to the lungs because the pressure stays high in the pulmonary artery because of that pulmonic stenosis.
For the overriding aorta though, like, is there any other implications other than both deoxygenated and oxygenated blood are going through the aorta?
It's just, it's inefficient. It's a little bit like a single ventricle.
Because that dotted line where it's like, is that like a displacement, like where it will go, or it like shrinks or something?
It is. So the aorta, some of the blood flow from the right heart is going directly into the aorta. The aorta is moved over a little bit, so it's inefficient. And it gets blood ends up even having more reason to skip the lungs, and because of that pulmonic stenosis. And when the kids have that TET spell and they squat, they increase the resistance in the body and pushes more blood toward the lungs. And so more blood gets oxygenated. And I did my cardiology in San Diego, and we went across to Tijuana, and we drove up to the cardiology clinic, and there was a kid in the front yard squatting, and everybody goes, "Look at that." It's so sad. He's a kid with TET, and you'd never see that now in the US because they get fixed before they would ever do that. But he's doing a TET squat. He was blue as that little man in your picture.
Really? You're not serious?
No, I'm serious.
Do people really get that blue?
He did. He was that blue.
Wow.
When he was squatting, and he pinked up a little bit from squatting. But wow. I love what the nurses said. The nurses said, if you sneak across the border and you can go to the emergency room at San Diego Children's, you will definitely get surgery. But we can't tell you that.
But we can't tell you that. That's wow.
Yeah, like when you go to San Diego, you encounter Border Patrol a lot.
I guess I just told you text.
So now I know need a chest, why we do it.
For this one, I couldn't believe that they haven't found a way to put in an artificial valve.
Yeah, I know. It did sound fatalistic. Like, why can't they put in a tricuspid valve? I don't know the answer to that.
Like, as far as we are, it seems like this is a relatively simple fix.
So we've got the left ventricle here, and then like an extra septum here. where like this extra chamber is coming from the left ventricle into the aorta or into the pulmonary valve, valve / artery.
Can't tell.
Like what's going, look, it just seems like this is like an extra chamber.
That's supposed to be the right ventricle.
Oh, I guess so.
Yeah.
So the blood is crossing it through the atria to atria.
Right. Okay, got it.
Through a ASD or a
Got it.
PFO. And sometimes it's hard for echo techs and even cardiologists to tell the difference between an ASD and a PFO.
So we'd have to close this, open this.
Mhm.
Can't tell the difference between ASD, that's atrial septal defect, and
pain frame of valley.
oh,
The PFO is present in all babies in utero,
right.
but it's supposed to close. It's kind of cool because it's a flap, and the pressure in the lungs is so high, the blood wants to go from right side to left side, but as soon as the baby's born, the pulmonary artery pressure drops, and so the flap closes, and then it's supposed to seal.
Does it drop in part because the lungs are full of air instead of fluid?
Exactly.
Oof.
So a PFO is a type of ASD. Let me just get that right.
I've never heard
Okay.
it said that before, but it is a defect in the septum, but everybody has a PFO, but not everybody has an ASD, if that makes sense.
But if the PFO doesn't close, it would end up becoming an ASD, correct?
Yeah, function like that.
Got it. Thanks, Anna.
Sometimes people have PFOs actually have a stroke because if a blood clot flips off their leg, goes up into their heart, and they have a PFO and they don't know it, or an ASD, it can get actually directly into their brain because it sneaks through the venous side and flips into their head.
And that's for like a full-grown adult or for a kid?
An adult can have it too if they have a small ASD or a PFO.
Wow. You could just go your whole life not knowing you have that.
Yeah.
So a lot of these, she mentioned increased risk for clotting. Which one was that again, you guys?
All of the cyanotic heart disease kids, their bone marrow is triggered to make more red blood cells. So the hemoglobin is too high. It's higher than it should be. So when your hemoglobin hematocrit goes up, your red blood cell count goes up. You get what's called polycythemia, and it increases your risk for stroke.
I would guess also you just have a more sluggish flow in your whole system.
Yeah, if it's bad enough, you could slow it down.
So would a CBC possibly indicate polycythemia, and that would lead the provider to think it could be a heart defect? Is that correct?
Yeah, but I think since pulse oximetry is so ubiquitous right now, I think it would cyanotic heart disease would always be picked up on pulse ox.
Okay.
All right, we're on 52 of 59. Are y'all good to go for a little bit longer?
Yeah. Let's keep going, if you don't mind. I'll stop asking so many questions.
This is the good stuff. This is the one that I've been waiting for.
Yeah. So when the baby's born with this kind of heart disease, they would die immediately if they didn't have openings where they shouldn't be. So the PDA keeps them alive, the ASD can keep them alive, or a VSD can keep them alive because blood gets shunted across and gets to the lungs that way. But it's like two separate independent circulation. Blood comes to the right atria, goes to the right ventricle, goes to the lungs, and then right back to the right heart again. And the systemic circulation goes body back to the heart, heart to the body, back to the heart, without going through the lungs.
So go here and then here.
Would they be born like blue?
Definitely. Actually, right when they're born, if they oh my gosh, they could have some pretty high O2 sats, like 87 or 88, and not look so bad. But within the first day, they look bad. And nobody wants to send a kid home with transposition or critical PS, the pulmonary stenosis. So the test where they do upper and lower extremity oxygen helps see disparity, helps them be suspicious of heart disease. So those kids all get echoes. The same reason there's elevated blood pressure in the kids with a patent ductus, the kids who have a ductus that's keeping them alive, it will change the oxygenation in the upper extremity versus the lower extremity, because that blood's actually sneaking across and going to the lungs. But transposition can look pretty good right at first, and as soon as the duct closes, they just get really sick and look really blue.
Can you see this on a ultrasound or?
Absolutely. Almost, there are very few babies born anymore. I mean, I think the people who do fetal echo, well, not fetal echoes, but maternal ultrasounds, most of them have kind of a source of pride in not letting a baby with bad heart disease get born without diagnosis first, because it helps so much with planning. You can make sure they're in a big major center that has a cardiologist and cardiovascular surgeons. And so it's really nice when it's picked up before. And this transposition can definitely be seen on a maternal ultrasound. And
So
then
does prostaglandin E cross the placenta? Can you give that before the baby's born so it gets in their system?
never heard of that. I don't think so. I think it's just given right at birth.
And would these babies most likely go on ECMO until it's repaired?
No, usually they look okay for a while. As long as you keep them on prostaglandin, you can plan the surgery. And they do the switch early, like in the first couple of days. But usually prostaglandin is enough to keep them alive.
That's good.
So this is where the ductus arteriosus would have been.
Right.
And then we were saying earlier that the PDA becomes a
narrowing if it's coart. I don't know if that's in the right picture right there.
Well,
That
this
looks
is here. It's not patent. Here, it's just the foramen ovale that is open.
Yeah. So definitely the PDA is important. And that's prostaglandin, that's really only for the PDA. I don't think it has anything to do with the atria.
Or it doesn't keep
these
that
are the
open?
kids. These are the. I think it just stays open. These are the kids that look blue and they're smiling and breathing really fast, but they're not working hard to breathe. They don't look like they're wearing out.
Huh.
And then their baseline for SpO2 is usually 60 to 75%. Is that correct?
Yeah, the physician kids. Yeah.
On the lower end, I heard the pulse ox is not very accurate. So
You're not as good. So if they say persistently below 90, there's a chart we use for birth, and it takes them 10 minutes to get up to 90. So we try not to use oxygen at birth, but it takes about 10 minutes to get up to 90. But they shouldn't be below that. So even if you do a blood gas and their PO2 is 65 and the pulse ox at 85, it really doesn't matter because they're both abnormal.
Okay, increased pulmonary blood flow. It's going to be patent ductus arteriosus.
Yeah.
Yeah. Yeah.
ASD.
ASD.
and VSD.
Yeah.
VSD. Uh-huh. Okay.
And is it the one, which ones are the ones where you shouldn't let the baby cry?
Any of the, not the ones that we just answered. So TET
And the ones with the TET spell.
and coarction. So these are the ones that we don't let them self-soothe. Is that right?
I don't know if I've ever heard the question before. I've never been asked that question.
She was saying that if it's a cyanotic or a baby that's getting decreased pulmonary blood flow, that we do not
Avoid.
let them cry.
Okay, that's great.
Is it?
Yeah, I think so. If they're, yeah, because you shouldn't see kids having TET spells anymore anyway.
Yeah.
If you try to soothe him and make him stop having the TET spell, then he's gonna not oxygenate as well. But I think, yes, definitely answer it that way.
Hmm.
Because they said it could even go so extreme if they keep crying that they might even sedate them.
Wow.
Wow.
Yeah, there was one that she was talking about that you can only do a bath like once a week because it could kill them if they get too stressed.
Critical pulmonic stenosis, they're real fragile. And that may be the one she was talking about, critical PS. So the basic, in congestive heart failure, the heart cannot handle all the blood it's getting. So it just starts pumping inefficiently because it's too full. And so anything you can do to help the heart eject blood better, decrease the workload, improving the oxygenation of the heart especially, and then getting rid of the extra fluid. It's just too much blood. It's an infant who has heart failure. Which would you expect? A would be just before the child died. Sorry.
Right. And they wouldn't have increased urinary output, right? Like that's what we want them to have increased urinary output, but
right, well, they don't.
Right.
So BCE. Sometimes I have trouble answering these, but I think I know the answer to this one.
I mean, this seems pretty like it's hard to not say that.
C is definitely right. A and B are definitely wrong. I think, I don't know what you're taught. We always say for DIG, if they throw up less than 15 minutes, repeat the dose, but only once.
Huh.
But I don't know if that's across the board. That's just what our cardiologist says. If it's less than 15 minutes, repeat the dose.
What did they say in the lecture? I don't remember this one.
It's C.
It's C.
Yeah.
If only one is right, then pick C for sure.
Yeah. It just seems like why would we not say this?
Yeah. Oh, definitely. And DIG is really it has a really narrow range of effectiveness. So too high makes them toxic and too low doesn't work. So it's one of the narrow therapeutic range drugs that some cardiologists don't like. Some cardiologists call it foxglove to emphasize how old it is. It's just ancient, but it helps. Yeah. So if only one answer is correct, it's definitely C.
Well, thanks so much, Dad.
You're welcome. Good luck, you guys.
Thank
you.
Hope you all make hundreds.
Thank you.
I hope so too. I hope I can save a life.
Yeah, have fun. I'm going to get a root canal. I did.
Have a good root canal.
Thanks. I don't think they're going to do it today. They're just going to tell me. They're going to tell me I need one, and then they're going to schedule it.
Oh, those are not fun.
They said they're better now. I don't know what they're like, but everyone says they're so much better at it now.
The drill still sounds the same.
Yeah. I don't know if I can bring. I bet I can bring music. Maybe I'll do that. Bye, you guys.
I ask for the blocks so I don't have to hold my mouth open.
Good idea. Okay, I'll ask for that.
Thank you, Dr. Rick.
Yeah, it's good to see you. Have fun. What's your dog's name?
Juno.
Say again.
Juno.
Juno. Awesome.
Hey, Juno.
What are you doing?
And let's get Phoebe in here. Hey, Phoebe.
Hey.
Come here, Phoebe. Say hi.
Yeah.
Oh, My dogs
Miss
are too
Carla.
short. My dogs are too short to get in the picture. They're corgis. I'd have to pick them up.
How's Pippa doing?
She's better. She's just kind of moping around. She's slow, but she's much better.
Irene, what's yours name?
Carlos.
Carlos.
Oh, there's 3. I didn't see that one. Yeah, you have to pick your dog up too. That's awesome, Carlos. Well, it's good to see y'all. I'll get my dogs on for the next one.
Okay.
Great.
Bye.
Bye, everyone.
Bye.
Bye.
Yeah.
Is Caitlin's dog an Aussie?
Looks like.
Gosh, I want one.
Carlos looks Hispanic.
They've got a name for it. Oh, I'll send it in the. I'll put it in the chat when I find it.
Okay. See you guys.
See y'all.
Thank you.
Annyeong.
Annyeong.